and probably 60% of my own practice is shoulder. So just so you get a point of reference. So, okay. So we okay? You want to start?
Yes, go ahead.
Okay.
Please.
So again, we're gonna primary, we're gonna be talking about rotator cuff injuries, but please feel free to ask as we go forward any type of questions regarding the shoulder. And if I don't mind if you ask, you can interrupt me. We can go forward. It's okay. It's actually better than waiting until the end. So we can go to the next slide.
Okay.
Okay, next slide. There we go. So as I said, the rotator cuff disease is probably one of the most common things that we see primarily in the shoulder, but out of all orthopedic ailments, I mean, I've been seeing patients already today for half the day, and I've probably seen about 10 patients with rotator cuff problems already. Okay, next slide. There we go. So as I was saying before as well that, well, that's okay, you can leave it here. As I was saying before as well that, you can have rotator cuff problems either from overuse, years of activities, whether it's people who are laborers or just, raking, shoveling and things like that over the years can certainly lead to rotator cuff problems. Or obviously if you fall down a flight of steps, slip on black ice, fall skiing, fall playing tennis, those things also can lead to rotator cuff problems. Next slide. Okay, so the rotator cuff it's a very common term, but the rotator cuff is made up of 4 tendons, the supraspinatus, infraspinatus, subscapularis, and teres minor. And the rotator cuff essentially envelops the top of the humerus or the ball in the socket, and it enables the arm to lift and rotate, but it also helps to keep the shoulder stabilized. The rotator cuff is actually what's called a dynamic or mobile stabilizer of the shoulder. So when you have injuries to the rotator cuff, it sort of throws everything out of whack. And the shoulder is an extremely unstable joint at baseline. That's why we can go all the way around. So the rotator cuff functions to help hold that shoulder in the right position, whether your arm is up above, in front of you, or behind you. And one other thing, if you see on the left, you leave it right here. Actually, you can see right here. If you see here, the biceps tendon comes up the front of the shoulder and is very intimately involved with the rotator cuff as well. So I like to tell my patients that injuries to the rotator cuff happen on a spectrum. Okay, it's not just, there's the beginning of it, which is tendinitis or a mild sprain or what's called bursitis. And as you can see there, the inflammation in this diagram and bursitis around the rotator cuff. And then those things can become partial tears or then full tears over time.
There is a question here, Dr. Font. What type of movement causes the damage to the rotator cuff so that we could avoid that type of movement?
Well, unfortunately, life gets in the way. And I think that you cannot really avoid it. So what happens over time is that, if you see where it's called the acromion process, that's the top of your shoulder blade. And I'll show you another slide how this goes. But over time, the space for the rotator cuff is so small. It's very small. And it's a thin tendon. So unfortunately, if you live a normal life, you put yourself at risk for that. So I always tell, look, everything in moderation. Live your life in moderation. If you stay flexible and stay strong, you limit the possibility of rotator cuff damage. But it's very difficult to say what activities, because, for example, lifting to get a dish in the kitchen on a top shelf, that's a strain to your rotator cuff, but you have to get the dish. So live your life. And if you just keep yourself in good shape and flexible, you should be okay.
What about pitching?
Well, pitching, I used to pitch. I was a pitcher into high school, and I have my own shoulder problems. Pitching is we could do a whole week-long lecture series on pitching. So when you throw, not just pitching, but when you throw, because there's so so much force on the top of the shoulder that the rotator cuff fires to help hold that shoulder in place as you're generating all that velocity. So again, if you are not in shape and don't have good core strength and good flexibility, pitchers tend to have rotator cuff damage over time. And if you do pitch for long periods of time, you may develop rotator cuff issues. My son's a pitcher, so he understands, but that's why there's what's called pitch counts or limits on pitchers so that we can not overtax someone's shoulder.
Thank you.
Okay. So there's other pathology that goes along with rotator cuff injuries. It's very common that when you get an injury to the rotator cuff, there are other problems as well. I very commonly see that the biceps tendon, as you can see in this diagram, is very close to the rotator cuff and is very commonly injured when there are rotator cuff problems. Arthritis also can occur and people will come in and say, oh, my rotator cuff is a problem, and I get an x-ray and they actually have very severe arthritis in their shoulder. So that's typically, people have a lot of misconceptions, and I always tell patients, look, you can look up shoulder pain on WebMD and find out, you can have a list of a million things. Let your doctor tell you what your problem is, and don't listen to your friends either, because chances are they don't really know either. But you can get a labral tear with rotator cuff pathology. The labrum is the cartilage ring that goes around the socket. It helps to give some stability as well. And then ultimately, the last thing, which is very common, which are impingement, which is, if you see on this diagram, that purple balloon there is the bursa. And when you lift your arm out to the side, that bursa and the tendon gets pinched in between the bones, and the tendons get aggravated. They can tear. That can lead to bone spurs and inflammation. So it's not really the bone spur that's causing the problem. It's the overuse and lifting the arm repetitively that caused the problem, which can lead to bone spurs and inflammation.
So can the hunch in posture we get from being on the computer that develops bad posture cause issues for the rotator cuff, asks Janice Cohen?
I don't think that because when you're on the computer, your arms are down, and these, as you can see just in this picture, your arm lifting up causes that compression into that area. So usually if your arm's down and relaxed with gravity, that's typically not going to cause a problem with your rotator cuff. It can cause other problems, carpal tunnel, wrist tendonitis, bad posture causes upper back problems. I mean, bad posture can lead to weakness of the shoulder, causing problems over time. But overall, sitting at a desk doesn't typically cause rotator cuff problems.
And you may mention labrum tears. So are rotator cuff issues a precursor to labral tears?
No, they're two separate issues. So the labrum is inside the joint. And as if you look in this picture, the labrum, you can't see, it's inside the joint where the ball and the socket articulate and join. So the labrum goes around that socket. So one thing we see a lot of, the biceps tendon attaches to the labrum. And when there's a biceps problem, it can involve the labrum. But the problem with the rotator cuff and the labrum are two separate issues.
Okay.
Now theoretically, if you have a rotator cuff problem, which leads to those stabilizers being thrown off, that can then lead to labral problems down the line.
And you also mentioned bursitis. So we have another question. How does bursitis relate to arthritis?
It doesn't. So it's an itis, right? So you can get them together. And itis, for everyone who doesn't know, means inflammation. So bursitis is that purple balloon there in this picture where you lift your arm up and it gets aggravated. Arthritis is inside the joint where the joint surfaces get worn down and you get bone on bone or wearing of the joint. So they can happen together, but they're not directly involved with each other. And I don't know if people know, but we have bursas all over the body, and you can get bursitis everywhere. The bursa is not inside the joint. Arthritis is technically inside the joint, if that makes sense.
That makes sense. To me, it makes sense.
Sure.
Now we have another question, but that's more about treatment. So I'm going to let you continue, and I'm going to ask you that question when we start talking about treatment.
Okay. Next, you can go next slide. So patient comes into my office with shoulder pain. So obviously the first thing we want to do is talk to the patient, try to find out why they're there, how long their pain has been, whether there's a history of trauma. We ask whether there's pain when they have their pain. Because this is a tendon muscle unit, very commonly there's weakness. And we typically will find that they have difficulty with overhead motion, lifting and reaching for things. And very commonly there's pain at night. If you see this picture and how this person's grabbing their arm, this wasn't just a stock picture. I picked this for a reason, because very commonly patients will come and say, oh, it's not my shoulder, it's my arm. But the rotator cuff, the way we're wired, is rotator cuff problems very commonly will give pain into the upper arm. So patients will come in and saying, it's not my shoulder, it's my arm, but it's coming from the shoulder. And I actually spend a lot of time trying to convince people that they're wrong, but it's okay. And then as we go through and I explain it to them, they get the idea.
What about, you said at night, why particularly at night?
You know, when we sleep, okay, depending on how someone sleeps, if you sleep with your arms up, you are compressing that rotator cuff consistently through the whole night. I don't think that causes tears, but that certainly is going to cause a problem. At night, lots of issues happen, neck, back, shoulders, even knees, because we're not moving around a lot. We move a little, but you need to have your shoulders moving and not staying in one position. And if we're staying in one position where your shoulders are up like this at all, that's going to compress and cause aggravation to that area in that spectrum that we talked about.
Okay.
Yeah. Next slide. Okay, so not only do we doctors talk to our patients, but we try to do a physical exam also. So obviously we want to see where it hurts, right? And you see if there's any swelling. Typically there's not swelling. Whether they have how their range of motion is, what's called passively, where I move their arm, or actively, how they move their arm. We see whether there's any atrophy or muscle wasting, where that can show that there's been a long-standing rotator cuff problem. And then how much weakness and how their strength is. And we test all the directions, right? Because we want to see the rotator cuff, again, is this, envelops the shoulder. So we want to see how strong they are in different directions. Okay, so lots of people will say to me, it's my tendon, I don't need an x-ray. I want an MRI. And everyone wants an MRI right away, okay? But the x-rays are very important, even though we can't see the tendons. Now, if you see the ball in the socket, right above, you see the two bones where that rotator cuff sits, and that is, that is a very narrow area. But this is a normal shoulder x-ray. So if you go to the next slide, I'll show you what abnormal looks like. So here are three different abnormal x-rays. Now, the one all the way on the left shows us what's called impingement. If you can see that acromion on top is sort of hooked over a little bit right next to the ball. And that's going to narrow the area for the rotator cuff, which makes you more susceptible to having some of these problems. Bursitis, tendonitis, things like that. Because on the left picture, if you go to lift your arm up, there's less space, it's going to cause more of a problem. The middle shows some calcium in the rotator cuff. There's a piece of calcium that sits in the rotator cuff. Now, that shows evidence that there's inflammation. Those patients have a lot of pain. If anyone on this who's listening has had calcifying tendonitis, is what it's called. It's extremely painful. And again, that's something that does not need an MRI also, because you can tell what the problem is. And then lastly, on the right, you see something called rotator cuff arthropathy, which is that there's no space between the bone and the acromion on the top and the ball. And you have this scenario. So you can see there's no space for the rotator cuff, which tells me that rotator cuff has been torn, and it's been torn for a long time. So understand, that's why we need x-rays, because they give a lot of information to us. So here we go now, right? So if someone has weakness or a traumatic event, or they give me concern on physical exam and history that rotator cuff has some damage, we get an MRI, which is, as people have asked me, does give much more information with respect to the tendons. So on the left, you have a normal rotator cuff. That black curved line with the arrow pointing at it is a normal rotator cuff. And on the right, you have someone that white, those arrows are pointed to, is space. And the rotator cuff is torn and pulled off towards the body. So that's a torn rotator cuff. You can go next slide. Okay. So now we'll get to treatment. Okay, so diagnose now. I don't get MRIs in everyone who comes in, because if they have good strength with some pain, very commonly we'll do some physical therapy. We may do an injection of cortisone. We may do some anti-inflammatory medications, and that's typically how we start. If someone comes in and says, I slipped on my driveway and I never had shoulder pain and now I can't lift my arm up, that patient needs an MRI to see if they ripped the rotator cuff right off the bone. But the more chronic patient pain for a couple of years, that's gradually getting worse, then we try these non-operative measures. The last thing I mentioned there, PRP, and that's, again, that could be a whole nother conversation, but that basically is what's called platelet-rich plasma, which is a newer biologic sort of treatment where we inject these factors, these growth factors or healing factors that we draw from a patient's own blood and inject them around the tendon. Now, there's not a lot of great research on this. I don't do it commonly because it costs money. Insurance does not pay for it. So although it's something I may discuss with patients, I kind of leave it off to the side as an option because I don't like to charge patients for things when I can't give them a good odds that it's going to work.
And we have a question. Can taking turmeric supplements help to treat arthritis, or do you need to do PT to reduce inflammation?
Well, so I think that supplements can help. There are supplements that have been shown to have anti-inflammatory effects, and I think that's I think that's great. I am a believer that there are many ways to treat inflammation. I think modification. One thing I don't have on here, which is extremely important, is if you're doing an activity, let's say you like to go to the gym and you tell me that every time I do this one exercise, my shoulders kill. Then what do you think I'm going to say? I'm going to say, okay, you need to bring that down a little, modify your activities, which is very important, and then treatment with therapy to increase strength and function of that rotator cuff in the shoulder will help keep that head, the humeral head or the ball, kind of contained. And taking anti-inflammatories, whether they're arnica, which is holistic, turmeric, or any other supplements, can help to reduce that inflammation. So all of these things can help to reduce inflammation. Depending on different patients will respond to different treatments. Okay, go next slide. Now,
there is one more question. Is there a reason?
Let me say one thing before you get there. So cortisone injection, I give a lot of cortisone injections, as does every orthopedist, because it's a very direct, effective way to reduce inflammation and subsequently pain, which is great. However, cortisone isn't benign, meaning it does have its own set of problems. If you give too many cortisone injections in one area, that can cause its own rupturing or damage to the tendon. So I will not, if someone has a full tear of their rotator cuff, I will not inject them. If someone has some tendonitis that hasn't responded to treatment or they're in a lot of pain, I'll do an injection. But studies have shown that more than one injection in the shoulder around the rotator cuff will adversely affect their surgical outcome. Excuse me. So if they need to have surgery at some point and they've had multiple injections, their outcomes are not as good. So I will use it in my treatment plan, but I don't do repetitive injections over time. I don't think it's healthy for the patient.
Mm-hmm. And another question that we have is about the PRP treatment that you were talking about. Is there any reason why the insurance companies don't cover that?
Well, insurance companies don't want to pay anything, so that's not surprising. But I will say that the studies that show, the insurance companies, well, let's back up. The FDA has approved some of these things for certain problems. There's a lot of what's called off-label use where it's not dangerous, but it's not actually what's approved. Insurance companies will not approve things that are not FDA approved for that particular action. But there's not a lot of great studies that show that PRP works for, say, rotator cuff problems. So it's difficult. Insurance companies aren't going to pay for something that may not work.
Mhm.
So that's why. And that's not just PRP, that's any expensive treatment.
And what about the use of CBD oil for treatment?
So currently, unless something's changed recently, CBD is not indicated for pain, meaning CBD is indicated, you can leave it there, indicated for anxiety. It's not indicated for pain. That being said, lots of people use it for pain and will swear by it, whether it's a topical or oral, whatever it may be. So I'm all for it. I think there's absolutely no downside to trying it. I'm a firm believer that I don't know everything. And I think that patients come to me and teach me every day as well. If they come to me and say, look, I tried this for my rotator cuff problem and it works, I'll if it makes sense to me, I tell my patients, look, I have one patient that tried this. Why not try that? Because the goal is making people feel better, right? That's the goal. And I think that if there are a lot of things out there that I don't know or didn't know at one point and I've learned over the years, arnica is a perfect example. I had my own orthopedic problems and I took arnica, which is a more organic anti-inflammatory that helped me. It doesn't help everyone, but I definitely bring it up with my patients because it's something I learned over the years.
Mm-hmm. And another question is, what you said about using the cortisone and not having the same results for surgery, does that apply also to knee or hip surgery?
So remember, when you're talking about an injection, there's an injection into a joint for arthritis, and then there's an injection around a tendon for that inflammation. It's all for inflammation, but when I'm talking about a rotator cuff, we're talking about repairing a rotator cuff. We're not talking about a joint replacement. So you can get, cortisone into a knee joint, which is a separate conversation, is not a problem. But getting repetitive ones can cause more breakdown of the cartilage. And you really try not to, if you get a cortisone injection with the idea of having surgery in the future, you have to wait to have a joint replacement at least 6 months to a year after you get a cortisone shot because the risk of infection is higher. So that's a separate problem. But this is getting cortisone shots around a tendon will cause that tendon to become damaged over time. So it's a little bit of a different story.
Okay. And when a partial tear heals, is it susceptible to tear again?
So one thing I didn't mention, and I should have at the very beginning, when I showed you that when you look at a tendon, what color is it when you look at it? It's white, right? And it's white in the body. And the reason it's white is because there's not a lot of blood in it. Muscles are red, and they're red because they have blood. So muscles heal very well. Tendons do not heal. So a partial tear may not heal at all. It doesn't mean it needs to be fixed. If the width of the tendon is like this, as long as a partial tear is less than 50% of that tendon in width, then the odds are it will respond well to conservative treatment, whether it be physical therapy, injection, whatever it may be. If that partial tear goes more than 50%, typically those patients may need surgery because the tendon has now been weakened to the point where the conservative treatment won't help. So to answer that question, partial tears, first of all, probably don't heal very well. They may scar a little bit, but they don't disappear. But that being said, it doesn't mean it needs to be surgically treated either. So if you have, if I had one shoulder has a partial tear and another one has no partial tear, the patient with a partial tear may be more susceptible to it getting worse, but it's hard to say. It depends on the patient.
Okay, thank you.
Okay, so I'm a surgeon. I do like to operate, okay, but I try not to operate on patients if I can avoid it, all right? But some patients, whether it's a full tear or a failure of conservative treatment, they may need surgery. And surgery, I was trained 20 years ago or more to repair the rotator cuff or treat it in an open fashion, meaning through an incision, and we go and treat. However, I have not had to do that in many years, and this is done very commonly through using a camera through small little what's called ports or little portals, as you can see in the diagram. So what we do is we make 3 or 4 little holes, sometimes 5 little holes, and we go in and look at the tear from all different angles. And then we're able to do a lot of treatments. We can do many complex treatments using the camera through small holes all over the body. Technology is amazing, and how things have changed in the last 10 years is amazing. And it's very important that surgeons read, go to conferences, look at new techniques. We go to cadaver labs to learn how to do these things. And the way I do a rotator cuff today is different than I did it 5 years ago, because I do this training and go to these conferences, read studies that show that treatment A has now shown to be better than treatment B. And it's very important. So through these small holes, we can clean up the area, like remove just some damaged inflammatory tissue. A decompression is where we smooth out and remove those bone spurs. We can actually fix the tendon through these little holes. And then we can treat the other things we talked about, whether it's the biceps, the labrum, and we can do a lot of things, as I said, through these small little holes. Okay, next. So I thought this would be interesting. People never understand, or you can tell them, but I think this is important to see. This is what it looks like. This is exactly what it looks like. So if you look at the picture on the left, the patient is sitting in very commonly in what's called a beach chair position, because it looks like they're at the beach. Their head's up a little bit. They are sitting in this thing, and that metal device that's sort of wrapped around is something that helps position the arm and holds it there, so that, remember, the rotator cuff is like a circle. So we have to look at different areas so we can rotate the arm around, and that will hold it there for us. And you can see on the right, couple little holes with the camera. And then with that blue area there on the right is just what's called it's called a cannula, where we can put instruments in and out very easily. So I thought this was a good picture to show, because this is exactly what it looks like when we operate. Okay. I like to draw pictures. I don't know if any of my patients are on the call. If they're not, I like to draw pictures. So I do a lot of picture drawing. So when you look at I draw these all the time. These are called anchors. Okay. This technology has evolved significantly over the last 20 years. They started out, they used to be metal, and now they're plastic. A lot of them are plastic. Some are all suture material. And they're implants that go into the bone. They're literally in real life about that big. And they go into the bone, and they have stitches attached that we use arthroscopically to repair the tendon and repair it back to the bone. And these will dissolve over time, which is important, because patients who have a rotator cuff repair when they're 55 years old, and at 70 they fall down again and tear it again, it's like we're starting over from new. If you have these still in the bone, it just makes it more, you can do it, it just makes it more difficult. You can go to next. Okay. So this is a picture. It's going to be hard but this is a picture of a rotator cuff tear. Arthroscopically, using a camera, looking at it. If you look at the left, on the bottom, it says footprint. That's where the tendon attaches, and the entire tendon is lifted up and torn. And this is a picture taken from the side of the shoulder. On the right is typically what it looks like after we're done, where you can't see those anchors. Those anchors are inside the bone, but then these sutures are used to repair that tendon and to sock it back. So it's a before and after, and this is a tendon that was repaired very well. And as you can see, it's pushed down onto the bone. And the challenges with this is, because there's not great blood supply. This is good. Yeah, leave this. This is not great blood supply, but that you have to really protect this over time so that your body will heal. And then just a couple of questions about this is a couple of, comments and additional things. So as I said, technology and improvements have been happening over time. We have better, you can go back to the other one, better anchors, meaning that the implants that we use are better quality. They hold in the bone better. The suture material, I actually use this suture now that's relatively new, that it's very interesting. And in water, and as we're doing these surgeries, there's water pumping through to help us see and to flush out blood and different things. But the suture itself actually starts to shrink over a period of time. So it helps to even compress and tighten up your repair better. Another thing I do quite a bit of is I'll use grafts, because this tendon is very thin. It takes a long time to heal. So I'll use these, as seen in this picture. This is a picture of a rotator cuff tear, but underneath the sutures is what's called a dermal or cadaver graft that goes on top of the rotator cuff that really helps to give it some more strength and I believe helps in healing. And this is one of the biggest, most, I would say the most common things that one of the most interesting things that I'm interested in, which is how can I get this to heal better? What augments can I do to increase healing and, get this better. So the last thing is biologic agents, which we touched on before, which is to inject PRP. There's a study I read actually yesterday about taking bone marrow from part of the shoulder and injecting it around the rotator cuff at the same time. Now, these things sometimes, the process for that is cost money. And so I like to do something before I repair a rotator cuff, I actually drill holes in the bone that allow all the good healing stuff in your bone to come out and help the healing. So these are a lot of the things that are newer that are happening now that cutting edge will say, but these are things that are happening more and more. Okay. So the biggest problem with rotator cuff tears is the recovery. It hurts a lot, but one thing we didn't discuss is anesthesia. So typically for these surgeries, patients will get what's called a regional block, or their arm will be made numb, and then they'll go to sleep. And that helps because when they wake up, they have less pain and they can start, they just feel better when they wake up. And these are done as an outpatient. But this hurts for a couple of weeks. I don't think it's as bad as it used to be because the pain control is better than it used to be, but it hurts and it's uncomfortable because you're in this little get up here for about 6 weeks. You could take it off for hygiene. You need it at night and full time for 3 weeks, but then all day for 6 weeks. Depending on how big the tear is or how stable my repair is, I'll start therapy anywhere from 2 to 3 weeks after surgery. And pain management is very important. Ice will be your best friend. It's the best anti-inflammatory, no side effects. I think we have ice machines that can work as well. And then taking anti-inflammatory medications and pain medicines are important as well. Okay, so tendons, when they tear soft tissues, take 3 months to heal. I don't care if you're 20, I don't care if you're 70, it takes 3 months to heal that to bone. So in that 3 months, we need to be careful. I have patients at 2 months that feel great. And I say, look, you have to take it easy. You have to go slow because you will tear it again. And I have patients, I had one patient recently, I repaired her rotator cuff and then she lifted up her 80-pound dog a month after surgery and she retore it. And I had to go back in and fix it again. So now, even though it takes 3 months to heal, it may take another 3 months to 9 months after that to mature and get stronger and get back to normal. So with these new techniques and the things that we're doing, I mean, if you do have good patient selection as well, right? So just because someone has a full tear doesn't mean it needs to be fixed. If someone is 85 years old, who's sedentary, who has a little bit of pain, but not a lot, and they can live their life and they have a full thickness rotator cuff tear, I'm not just going to recommend fixing it because it's there. I think that we need to, be smart as surgeons and doctors and do the right procedure for the right patient. And sometimes, patients who I treat differently based on their activity level. And I just had this conversation this morning with a patient, which is that patient sitting in that chair in front of me is different than the next patient, even if they have the exact same problem, because they have a different lifestyle, they have different needs and different desires as to what they want their body to be like. So things that can make, lessen your success rate as surgeons and where there's an increased failure of that tendon healing, smokers, people over the age of 65, and whether they've had previous surgery. Now, that doesn't mean I won't operate on a smoker, or that doesn't mean that someone over 65 won't heal, or whether they have previous surgery. But I think it's important as doctors that we communicate that to patients so they understand that they're what we're dealing with and what their success rates will be. Any other questions?
No other questions so far. So please feel
I got it.
free.
All right. Well, the talk. Well, okay. Well, I'll say that the talk is done as far as the slides, but I will say that the biggest area of research now, one of the biggest areas in orthopedic surgery is to try to get tissues to heal stronger and faster. And whether they're implants or the biologic agents we talked about, or more intensive therapy, it's really advancing every day. And as I said, the way that I do rotator cuffs has changed and continues to change. And although I'm a surgeon and that's my interest is how to fix these things and how to, do them more expeditiously and with better success rates, prevention is key, right? So eliminating those things that may cause these problems, keeping strong, keeping fit. And I think that's going to help everyone, right? So the patients that, if a patient does come to me who is in shape and is doing, and they do happen to have a rotator cuff tear, those patients are going to do better post-operatively as well.
I have another question here from Alex Garcia. He says, I do a lot of decline push-ups. I'm 46 years old. And can I do seated bench press? I'm asking because I'm in the process of weight loss besides keto diet. Will this procedure disable me from work? I work in the IT field.
Okay. So a general sort of issue about exercise. The shoulder, I take care of a lot of weightlifters because the shoulder was not meant to deal with some of these stress. So just a general, this is what I tell a lot of patients is, you should not be going back like this with weights, okay? Meaning you should try to keep everything out in front of you, because as you start to come back and your hands start to disappear from your peripheral vision backwards, you put a lot of stress on your shoulders. Let's see if you can see my shoulders. A lot of stress on your shoulders. So I think exercise like decline bench or bench pressing puts a lot of stress on your shoulders and can cause injury. But a way around that is to basically, I told the patient the other day, if he wants to do bench press and his shoulders bother him, go on the floor so that when you come down, your elbows stop, right? Or if you're on a bench, if you put towels here, if you're using a flat bar, you'll stop there and be able to go up to remind you to do that. And I think that that's important to modify that way.
Yeah, I like how you say that, like we need to keep our hands visual at some point. I think that's a good measurement as well.
Yeah, back here is bad. It feels like people love that stretch in their chest, but it's not good back here. So I just tell you, keep everything out in front, okay, and keep it here, and then you're protecting your shoulders that way.
Mm-hmm. Do you notice any difference between males and females, as who suffers more rotator cuff injury, or is it the same, or is there like an age range that we should be looking at?
A lot of these, you have these bimodal sort of injury ranges, right? Younger patients tend to have that, traumatic recreational type injury, and patients as we get a little bit older will have this more progressive wear and tear problem. So, I think that I think women who are middle-aged women and women in their 50s, give or take, who are thin and have fair skin have a susceptibility to get stiff. That is true. So I think that those patients have that set of problems that aren't truly just a rotator cuff tear. That's one. The second thing is younger patients have they have good blood flow. And this doesn't just have to do with shoulders. So patients sometimes who have good blood flow, that's great for healing. The problem is they develop more scar tissue as well. So sometimes younger patients will have more stiffness afterwards and things like that. But I think, it's very hard for me to tell you that it's women or men. I think that I see it equal of both.
Are there any exercises that we can do to prevent rotator cuff injury?
Yeah, so when a patient comes in and they ask me a question like that, I'll typically recommend that they see a therapist once to let them physically go over the exercises with them. Very light weights, The band exercises people have seen, these rotational and forward exercises that you can do to strengthen that rotator cuff to help shoulder function and prevent tears. So the answer is yes, there is. And I think there are a lot on the internet. So I just saw that pop up. So no, I'm not. I just said you can use weights or resistance bands. I think anything. So when you want to work out these muscles, your big chest muscles or your deltoids, those are bigger, heavier weights. And that's fine as long as you're using proper technique and you're not overtaxing yourself. I think that when you want to work your rotator cuff, that's a very small tendon. So that's something that specific band or lightweight exercises will focus that more on the tendon. And people can look this up online. There are lots of good exercises to do. So to answer that comment, yeah, I think that weights and bands are good, depending on the muscle group you're
And once
on.
the point comes to have surgery, that is covered by insurance, right?
Yes.
Okay.
Yeah, it's the insurance is covered. The insurance covers the surgery as well as look, I will say that sometimes I'll have a surgery. I have a patient who tears the rotator cuff, and I schedule them for surgery, and then the insurance company declines, and then I have to go through the process of speaking to them and talking about talking to the insurance company and to their representatives, and sometimes it takes a little bit of a fight, but typically it gets paid for.
Mm-hmm. And we always get this question about any dietary changes that you can do to protect your muscles in general, and especially your rotator cuff in this situation.
Well, I will tell you, diet's very interesting. Diet over the past few years has become an extremely involved with all of our health, right? So there are certain diets that may increase inflammatory responses. There are I personally think if you have a well-balanced diet and you're getting the proper intake of nutrients and vitamins, you're fine. And then combining that with staying in shape, doing these exercises to keep yourself flexible and fit, I think you're fine and you do it. I don't think there's no specific, look, people may see things where, if I eat shark cartilage, that's going to help strengthen my tendons. I don't think there's a lot of studies to back that up. If someone comes in and say, should I stop taking shark cartilage? I'm not going to say yes, they can take it, but I don't have any true data to tell you that taking this supplement will strengthen. That's why I think that balanced diet and good flexibility, staying fit, I think that's your best, and modifying your activities to avoid the extremes. Moderation is important. I saw a question there about surgeries. When would I open up a shoulder as opposed to, I would argue that at this point, it's easier. The bigger tears are easier to do with a camera than open. I can't tell you it's been years since I've ever opened up a shoulder for a rotator cuff tear. So sometimes I'll make a separate incision for the biceps tendon, which is separate, but with respect to the rotator cuff, because of the way technology has advanced and techniques, there's no reason to.
And I think we only have time for one more question. When is time to seek a doctor? Because, sometimes we just feel pain and we try to, Tylenol it, so to say, and don't seek help.
It's a tough answer because I believe everyone needs reassurance at different points, right? So some people, if they have pain for a day, start to freak out, and I'm happy to be the one to tell them, don't freak out. But so I think, look, if you have a strain or if you wake up one day after a huge snowstorm and you just shoveled and your shoulders are sore, I don't think you have to go to the doctor. I think that you take some Motrin or Tylenol and give it a little time. I think that's typically fine. However, if you fall down or you see you have a significant trauma that leads to weakness or significant pain, I think that's the time when you need to see the doctor, because there is a time base with respect to whether it's a fracture or a tendon rupture. I just saw someone the other day who tore a tendon, who waited 3 to 4 weeks to see me, and now that's a problem. It's going to compromise his outcome potentially. So when you have a traumatic event, I think it's important to go sooner than later. With more longstanding problems, that's up to the patient. I'm happy to see someone if they've had pain for 2 days. I'm happy to see them if they've had pain for 2 years. It's completely up to them, what they want to tolerate. Sandra, I can't hear you.
I forget to unmute sometimes. So I was just saying that's why I love having you here, because, you know, time flies. When we're talking to you, we get so many questions from the community. It's really great having you.
Yeah, it's a good thing. I could keep talking, so I'll just keep going.
No, that's perfect. That's exactly what we need. So I'll probably, you know, we need to find another topic to talk about, and I want you back again and again. And, you know, we have only 3 minutes left. So let me tell you a little bit about what's coming in these community Zoom chats. Next week, please don't miss it. If you're into vegetarianism, or if you would like to learn more about vegetables and how to cook, we're going to have a vegetarian chef. It's our own Chef Mike, and he's even going to be doing a cooking demo. I'm not even sure how we're going to do that, but we're planning. It's going to be amazing. So please join us for that. And after that, falls prevention. And don't forget, March is colon cancer prevention month. So make appointments, take care of your health. And we're going to close colon cancer prevention month on April 1st with a presentation from our gastroenterologist to talk about colon cancer. So please join us. Thank you so much, Dr. Font. Thank you to all of you who participated today. And without further, yeah, go ahead.
Yeah, no, I was just going to say, you know, look, I'm, you know, now that, you know, I have this, I have no problem in answering, you know, emails or people have questions, and I'll give my email if you want to. It's jfond, F-O-N-D, MD at neosmteam.com. And my practice is Northeast Orthopedics and Sports Medicine. I do a large amount of shoulder. I see a large amount of shoulder patients, but we have a wide variety of doctors who can take care of all these things. But I'm happy to answer emails or any questions you may have.
Beautiful. Thank you so much for that. I just wrote it in the chat box. Please check that I didn't misspell anything.
Let me see.
Northeast Orthopedics and Sports Medicine.
Let me see. Here, do you want me to? I don't see it there. Do you want me to do it?
I just, okay. Let me see. Looks like I just I just put it for one person. Okay, all panelists. jfund at
I'm sorry for the initial technical issues.
Okay.
I have to deal with that. I know.
No, it's fine. You know, I think everybody's used to know that we're living in a modern era where we are all new to this. So I think we are very understanding of that. So well, how Sandra, is that? Do you see it?
Let me see. It's JFON MD.
Okay.
The JFON MD at neosmteam.com. Yeah, Sandra, I appreciate it. I think it's really important that people get this information. I think education, even though the internet, I'm not one of these, I think people can go look up things on the internet. I think that's fine, but there is a lot of misinformation out there. And I think please listen to your physicians, because although people's friends are very vocal about they think that they know, even if they did have a similar problem, there's a lot of telephone game that goes on where they get misinformation from their friends. So, but please, anything anyone's needs, and I really appreciate it, Sandra. Thank you.
Well, thank you very much. And I think that, you know, don't blame me if you start getting a lot of emails and questions.
I honestly don't mind.
Okay, great. Thank you.
Okay.
And you just said it correctly. That's one of the reasons why we're doing this, because, you know, we know that there is a lot of misinformation, and we want to make sure that people get professional expert information, you know, to treat your health, which is so important. So thank you all. Thank you, Dr. Font. Again, we'll chat because we need to do more work with you. And have a very good afternoon, everyone.
You too. Thank you. Bye.